in Saudi Arabia, it's the time to start our webinar today. Today is the seventh webinar that's organized by the Saudi Ophthalmology Society. And today we have really a special webinar, and we are really honored to have Dr. Kikawa. Dr. Kikawa is a professor and of ophthalmology at University of California, San Diego. And he's a world expert in the field of orbital and oculoplastic surgery. And today he's kindly accepted our invitation to share with us his thought and experience with the new therapies for thyroid eye disease. Dr. Kikawa, would you please go ahead?
Thank you very much, Dr. Dell. It's an honor to be invited, and I send greetings to all my friends and colleagues in Saudi Arabia, and I wish you all the best during this time of need for everybody. So good health to all of you, and thank you again for the invitation. So I do have some disclosures. I'm a consultant for Horizon Therapeutics, as well as we do get book royalties from Elsevier Publishing, and I will be discussing some off-label use of medication. Let's start a little bit with the epidemiology of Graves' disease. It does affect females more than males in about a 6-to-1 ratio. This is the pattern that most autoimmune diseases show. However, when men get the disease, they usually get it worse. Smoking is not usually causal of the disease, but people that do smoke usually also have it worse. And approximately 20% of patients with Graves' disease will have some eye involvement at one point in their life. It may not be severe, but it is quite common. Let's talk about the signs that we see with thyroid orbitopathy. So the most common sign is eyelid retraction. And all of you know that this is the distance between the lid margin and the central corneal light reflex. And if we look at this patient, we see that the upper lid margin is about 2 to 3 millimeters above the corneal limbus. We do know that the vertical corneal height is about 12 millimeters. So the MRD for this particular patient is about 8 millimeters. George Bartley did a large epidemiological study in Olmsted County in Minnesota and found that this was the primary diagnostic criteria for thyroid eye disease. And it was highly specific, meaning that if there was no lid retraction, that could call into possibility of other diagnoses. But if the patient did have lid retraction, it was highly correlated with having underlying thyroid eye disease. The second most common manifestation is exophthalmos or proptosis. Try not to get that confused with lid retraction. This patient actually has both, but sometimes we see that lid retraction may not be present in patients with proptosis. We also know that proptosis varies with gender as well as ethnicity, but the upper limits of normal is about 20 millimeters in most patients. Some of our thyroid patients may have 30, even greater than 30 millimeters in severe cases, such as this patient. We do measure proptosis by the exophthalmometer. This is an example of a Hertel exophthalmometer. And you can see on the closer magnification view on the right side that we look for alignment of the anterior corneal surface with the gradations on the exophthalmometer. So this particular patient has a reading of about 18, which is normal. But as you can see, the gradations on the exophthalmometer go up to about 30, which we sometimes see as in the previous patient. Thyroid orbitopathy can also affect the extraocular muscles, and we know that the inferior and medial rectus are the most common muscles affected. However, in severe cases, it can affect almost every extraocular muscle, including the oblique muscles. Typically, because the inferior and medial rectus are involved, we will either see an esotropia or a hypotropia as seen in this particular patient. So this patient, as you note, has very asymmetric disease. The left eye is essentially normal, and the right eye is not only proptotic, but has a large angle hypotropia. And this is most likely due to a large inferior rectus muscle. Thyroid eye disease happens to be one of the manifestations of the eye that affects almost every ocular tissue. And consequently, it involves almost every subspecialty of ophthalmology. including even our glaucoma specialists and cornea specialists if there's any anterior segment involvement. But our glaucoma specialists get involved because of the tight inferior rectus muscle that can cause elevated intraocular pressure on upgaze, as well as other fields of gaze. And as I mentioned, in severe cases, we do see optic nerve dysfunction. This is an example of a swollen nerve. The nerve, however, may not show any swelling. It may not even show hyperemia. But in those cases, it certainly is a tip-off for optic nerve compression. And as we do see in this associated visual field, there may be an enlarged blind spot or a paracentral scotoma. And certainly urgent intervention is needed in these cases. There is a spectrum of eye involvement, and there usually is a division of what we call type 1 disease and type 2 disease, which I will subsequently discuss. But type 1 disease is primarily fatty infiltration. So if you look at this patient, the patient has proptosis as well as lid retraction. But if you look at the CT image, you'll notice that the muscles are fairly normal in size. There is, however, a preponderance of orbital fat causing the protrusion. Because the involvement is primarily in the orbital fat, you'll notice that the eyes here are very white and quiet, and there are very minimal signs of inflammation. Contrast that with this patient that we call type 2 disease, where there is enlargement of the extraocular muscles and inflammation. You can see on imaging for this patient that there are very large medial recti as well as lateral recti muscles. And because of the inflammation that occurs, you'll see that the eyes here are more inflamed. There's injection over the extraocular muscles. The conjunctiva can be inflamed. And these patients may also develop eyelid edema as well as eyelid erythema. It's sometimes not easy to categorize each patient as a type 1 or type 2, and oftentimes we think that this represents a spectrum of involvement, and the involvement of one tissue versus the other occurs on either end of the spectrum. So some patients may have a combination of both. This is an activity curve modeled after Rundle, and on the y-axis we have disease activity. On the x-axis we have time. And you'll see that there's a fairly typical activity over time, meaning that the disease gets worse, it becomes stable, and then there's some spontaneous improvement. And the typical thinking is that medical therapy should be instituted in this area of deterioration or active clinical worsening. And the thought was that once patients become stable or even slightly improved, that medical therapy is not really effective. I do have a case that I'm going to show a little bit later that might question this previous dictum that we've all come to accept. One additional caveat is that any surgical improvement should be, or excuse me, surgical intervention should be reserved for the part shaded in green when the patient is stable and even slightly improved. We do perform surgery in this red shaded area if the patient does have threat to vision, such as optic neuropathy. There are several collaborative groups nationwide, as here in the US as well as globally. There's UGOGO, which is the European Group on Graves' Orbitopathy. This includes endocrinologists as well as ophthalmologists. And there is an ITEDS group, which is a global society. And then there's university-based centers in the US. And just to name a few, there's one at UCSD, at the University of Michigan, and University of Minnesota. Let's talk about classification. So we have to understand that there is no one ideal classification scheme. The most widely used is what's called the clinical activity score. And this mainly judges whether or not the activity of the disease is active or inactive or chronic. The clinical activity score does not include severity. So for example, if the patient is asymptomatic and has a exophthalmometry reading of 30, but the eyes are quite white and quiet, the clinical activity score is 0, but the patient may have severe disease. Conversely, in an early case, the disease may not be that severe, but it could be active. There was a classification scheme called NOSPECS. This was somewhat problematic and has been largely abandoned. And then the VISA, which was described by Peter Dolman and Jack Rootman in 2006, does actually combine some activity and severity. So that's another option in terms of grading. So the actual clinical activity score is the most widely used, and that's probably what a lot of the studies relied upon for the determination of active or inactive disease. So just to go over this particular patient, 1 point is given for each of the following findings or symptoms. So if the patient has spontaneous orbital pain, that was 1 point. If the patient had gaze-evoked pain, meaning if they looked around and the pain worsened, that was worth a point. Eyelid swelling was 1 point. Eyelid erythema or redness, 1 point. Conjunctival injection was 1 point. Chemosis, as well as inflammation of the caruncle or plica, which you can see on the inner corner of the eye. And this patient happens to have all 7 findings. So her clinical activity score is 7. You could gain an additional 3 more points on follow-up exam if the patient has worsening of proptosis by more than 2 millimeters, if there's any worsening of strabismus or decrease in Snellen acuity. So for the initial CAS score, there's a maximum of 7. However, on follow-up exam, you could gain an additional 3 more points. Imaging is used quite frequently, and most of our evaluation for thyroid eye disease should include some sort of imaging. And the question of CT versus MRI is one that's debated very frequently. Obviously, there is some benefit to each. On the slide left, you see a CT scan, which shows good bony detail. So usually for preoperative scans, we prefer a CT because we're able to see the volume of bone as well as the status of the sinuses. However, you can see that the detail for soft tissues is not great. Contrast that with a MRI of the orbit on the right side of the slide, and you can see that the soft tissue detail is much greater. This is with contrast or with gadolinium, and you can actually see highlighting of the medial rectus, which indicates that there probably is some active disease going on, and that's the level of detail that we just don't see with the CT. This is a coronal view of the same patients. And these are not the same patients, by the way. These are 2 different patients, one with the CT and one with the MRI, if you're wondering why the muscle sizes look different. But again, you see the level of detail for the soft tissues is much greater with the MRI. And for bony detail, we prefer the CT. So there may be some benefit to getting both scans. One thing we noticed upon seeing many patients with thyroid eye disease is that the appearance can change very slowly over time. So this is a patient's self photos, and you can see over these series of 4 photos, which occurred over the period of several years, that her appearance very slowly changed. The second photo shows a little bit more lid retraction. The third photo shows even more. And then the last photo on the right side of the slide shows a large degree of proptosis, as well as strabismus and lid retraction. And one thing we note with these types of patients is that it does affect them mentally. They don't look like themselves. They may withdraw from social circles. It's difficult for them to work. And we do need to consider the mental health burden. And again, as ophthalmologists, we don't necessarily consider ourselves experts in mental health, but we certainly can refer patients for evaluation to a mental health professional. And we should consider the psychological burden that it does have a great effect on patients. Let's talk about the therapeutic approach. So in more mild cases, we certainly observe, but the stage treatment consists first of supportive care, medical therapy, and then any possible surgical therapy. So supportive care is usually the use of ocular lubricants, artificial tears. We prefer the preservative-free. Could consist of lubricants. We strongly encourage smoking cessation and stress reduction. And then selenium, 100 micrograms of BID, has been shown to have some benefit in mild cases only. So this is usually recommended for mostly every patient, particularly those with mild disease. We encourage the first three things in almost every patient: lubricants if needed, smoking cessation, and stress reduction. Some of the questions that we have with instituting medical therapy, though, however, are somewhat thought-provoking. Does any therapy really alter the endpoint of the disease? And these are rhetorical questions that we really don't know the answer to. Or do they primarily hasten the resolution of the inflammatory phase? And then finally, who should get medical therapy? In our practice, we reserve it for the severe active inflammatory patients with mild to moderate disease, so clinical activity score of greater than 3. And we typically don't use any medical therapy other than the supportive care for mild disease. So medical therapy consists of medications, which can be either given IV or orally, or even by injection around the eye. Botulinum toxin is used primarily for patients with strabismus. As you all probably know, botulinum toxin was first FDA approved for strabismus. So in patients with large or even small angles, our strabismus specialists do use that to as a temporizing measure for the deviation. And then external beam radiation therapy can also be used. Radiation for thyroid orbitopathy has been somewhat controversial. Some studies show benefit, others don't. It's primarily used for optic neuropathy, severe inflammatory disease, and strabismus. And the dosage is about 2,000 centigrade. And this is considered a low dose. A patient may develop some dry eye. However, the risk of optic neuropathy, radiation retinopathy, and cataract are reduced with this lower dose. And the benefit of radiation therapy is found not to be additive to medical therapy. So if the patient was already on medical therapy, additional radiation therapy was not found to be useful. General classes of autoimmune treatment for drug therapy include non-steroidal agents, and these are used mainly for symptomatic relief. There's steroids, there's cytotoxic agents, and then there's a newer class called the biologic response modifiers that are genetically engineered. So let's talk briefly about some of the major categories. Oral steroids have been used quite frequently for thyroid eye disease. In our practice, we use it for short-term use only. We don't keep patients on for a long period. So when I say short-term, we're talking just a matter of a few weeks at most. We use it mainly as a therapeutic trial. For example, if the patient comes in with inflammatory signs or even early optic neuropathy, we will, as a temporizing measure, start steroids, but then we taper them off and consider other treatment for more long-term use. The other use for steroids is that it could be used for radioactive iodine worsening. So there have been studies that show that radioactive iodine, the treatment for the enlarged hyperactive thyroid gland, can cause a worsening of orbitopathy. And the thought is that as the thyroid gland becomes destroyed, that the cells release additional antigens, and that can cause a worsening of the immune response to the periorbital tissues. And it's been thought that about 15% of patients might worsen who have radioactive iodine. And this was confirmed in a study back in 1997 by Bartolina. And he basically took a series of patients treated for radioactive iodine and randomized them into two groups. Some got steroids, some did not. And it was found that the effect was blunted in the patients with steroids. So we do consider steroid treatment in conjunction with our endocrinologists in patients that are high risk, and these are patients that are smokers or patients with moderate to severe disease. The dosage for oral steroids is prednisone 0.5 milligrams per kilogram per day for 4 weeks, and then an 8-week taper. Subsequent studies showed a lesser dose for a shorter period of time was also effective. IV steroids are more efficacious than oral steroids with less side effects. As you know, chronic steroid use has problems of the Cushing-Boyd phenomenon and elevation of sugars, and it's not quite seen in that degree with pulsed IV steroids. There's a few varying protocols for IV steroids. 1 gram IV methylprednisolone daily ×3 has been used. The 500 milligrams weekly ×6 is probably tolerated a little bit better by patients. Just be aware that higher doses cause dose-dependent liver toxicity, and there have been reports of liver failure and death from usually doses of greater than 8 grams total. This is a patient who had IV pulse steroids. Here she is after 3 infusions, and we treated her with the weekly, the 500 milligrams weekly. So you can see that it does reduce inflammation. Another possible route of steroids is the periocular injections, and Ebner from South America published in the BJO back in 2004 that 20 milligrams of triamcinolone given weekly ×4 in the inferolateral quadrant was associated with improvement in the inflammatory reaction, as well as in some patients with strabismus. This is a photo taken from his article showing this patient who had a greater area of binocular field, as well as lessening of muscle diameter on CT imaging. So again, this is periocular steroids. And there didn't seem to be any increase in intraocular pressure associated with this. So cytotoxic agents, many have been tried. Methotrexate, azathioprine have been tried with varying success in controlling inflammation. There was one study that did show that the addition of mycophenolate to IV methylprednisolone had a greater effect than the steroid alone. So that could be a possibility if the patient is a candidate for mycophenolate as an additive effect for IV steroids. Biologic therapy is probably the newest arm of treatment for thyroid eye disease, and there are 2 medications that have been studied extensively in the past. These are off-label treatments. Rituximab is an anti-CD20. It's on-label for lymphoma, off-label for thyroid eye disease. It's been studied extensively in Europe, and some studies do show a reduction in clinical activity score similar to steroids. Tocilizumab is an anti-IL-6 monoclonal antibody. It also is off-label for thyroid eye disease. It's on-label for rheumatoid arthritis and giant cell arteritis. And one study did show effectiveness against a placebo in reducing the clinical activity score at 6 weeks. The newest FDA medication is teprotumumab, and this was studied extensively in clinical trials. And both in the phase 2 and phase 3 trials, it did show dramatic reduction in clinical activity score and improvement in symptoms. And it was FDA approved in January of this year for thyroid eye disease. So just in brief, the way the teprotumumab works, again, it's a monoclonal antibody against IGF-1. Terry Smith was really the thought leader and pioneer in getting this medication through FDA approval. But the reason it works is that the IGF and TSH receptor are co-localized on the orbital fibroblast. So if you look at the orbital fibroblast, the IGF-1 receptor is almost like an innocent bystander to the TSH receptor. But if you block the IGF-1 receptor, you also block the TSH receptor. So they're co-localized. And what that does is it inhibits the inflammatory cascade. And the IV infusions of teprotumumab occur through a series of 8 infusions over 24 weeks. So each infusion is spaced out at 3-week intervals, and the dosage is 20 milligrams per kilogram. So this is a patient of mine who has undergone full treatment with teprotumumab. He's a 71-year-old who presented with puffiness around his eyes and pressure for about 6 months. Interestingly, he was treated 9 years prior with radioactive iodine. However, never developed eye symptoms until fairly recently. And here's his imaging is showing enlarged extraocular muscles. And then as you can see on his clinical photo, he does have eyelid edema, erythema, chemosis, proptosis, and conjunctival edema. So his vision was 20/20 on examination. We did judge his clinical activity score to be 4 based on the findings that I just mentioned. His exophthalmometry readings measured 22. And his response was quite marked. This is him after 8 cycles of teprotumumab. He underwent the full treatment, and he had a 3 mm reduction in proptosis. You can see his edema has improved, his inflammation, his chemosis and injection has improved, and now his clinical activity score is 0. This is a patient that we presented in the AJO. So this is an interesting case. And this brings up the possibility that maybe there is a larger therapeutic window of treatment than we initially thought. So this was published by our fellow DJ Ozello in the AJO case reports, co-authored by Dr. Korn, and this is a 50-year-old patient who presented with a 3-year history of Graves' disease. And she had 2-year stable proptosis readings. So her exophthalmometry, as you can see, was much worse on the left side. She had very asymmetric disease. However, she was largely asymptomatic in terms of her swelling and inflammation and chemosis. You can see that she did have enlargement of her extraocular muscles, particularly the medial rectus, but her clinical activity score was only 1, and that was mainly because of her pain. This is the type of patient we normally would offer surgery to, but she was not a good candidate for surgery due to her concurrent medical issues. So we did offer her teprotumumab. Here is her clinical activity score on the right side of the slide, now 0, and she's had improvement of her extraocular muscle enlargement with reduction of proptosis in both eyes. So, this case is unique in that it might represent an expanded window for treatment. We don't actually know if how long patients respond, but certainly this did call into question our longstanding understanding of the clinical activity due to Rundle's curve. Some of the side effects of teprotumumab, there could be elevated glucose, there could be muscle cramping, potential dysacousis. So some patients developed some hearing loss and issues on the clinical trials. These did seem to improve. There could be general malaise. And then this medication is highly teratogenic. So any childbearing women who are on this treatment should be offered contraception. So treatment discussion with teprotumumab, it appears to be effective medical therapy for mild to moderate disease with a fairly good profile of side effect risk. Because it's acting on the co-localized receptor for the TSH receptor, there is no immune suppression, which differs from other treatments that affect the immune system directly. There may be some risk of relapse that was seen in clinical trials. However, most patients had a sustained effect. The economics of care do need to be considered. This is a new medication, and some of the costs still are being figured out. Third-party payers right now are covering it, but it can be costly for the patient and insurance companies. So the final topic we're going to discuss is staged surgical rehabilitation. So let's just say that medical therapy is not successful, and we are having a discussion with the patient to perform surgery. So typically there is a staged process that occurs. If orbital surgery is performed, we will perform that first, and this is typically orbital decompression to expand the orbital volume to create more space for the soft tissues and allow the eye to come in. Remember that as we do expand the orbital space, these large muscles can pull a little differently. And one of the potential side effects is that the eye may shift off alignment. And I have this discussion with patients before the surgery. I say that if you do get double vision, it doesn't mean that the surgery was not successful. We know that it's a known side effect, and that just the fact that these new muscle, the space that we create for the muscles, might cause them to become off alignment. And again, I think if you prep patients that this could be a possibility, they will understand that and not think that the surgery didn't go well. So you do have to warn them that that's a possibility. And then finally, there could be the need for eyelid surgery or any sort of blepharoplasty after. And one point to consider for surgery is, other than prevention of disease or turning back the clock, surgery is one of the only ways to restore the pre-disease state. And again, maybe with the expanded therapeutic window for teprotumumab, this may not be the only option, but it used to be thought that once patients went through this inflammatory phase and became more stable, that surgery was the only way we could try and get them back to how they were. So let's walk through a series of surgeries for this particular patient. As you can see, he has severe proptosis, severe chemosis. He was not responding to medical therapy and underwent orbital decompression. So on the right side of the slide, you see that his proptosis is markedly improved. His inflammatory signs have also improved. However, there was an inducement of a fairly large angle esotropia. So after the alignment became stable, he had strabismus surgery, which consisted of medial rectus recession, as well as inferior rectus recession, as his superduction was limited. And as you all know, the eyelid is linked to the rectus muscle. So with recession of the inferior rectus, you can see that the lid is also now retracted, but certainly his eyes are in much better position. So the final step would be to correct his eyelid retraction. As seen here, we perform lid retraction repair as well as hard palate grafting to elevate his eyes. And then as you can see from start to finish, this is before and after stage surgery for the result that's possible. Looking at CT imaging before and after, this is the areas of bone that we target. So you can see on the right side of the photo, which is post decompression, you can see that the lateral orbital wall has been burred out and allowed the soft tissue to expand, as well as the medial orbital wall. And the tissues now have access to the greater space in the ethmoid sinus, as well as a posterior orbital floor decompression. As you can see that the floor space has now been improved, and that can now enter the superior of the maxillary antrum. This is another patient before and after decompression. And the schematic diagram here shows areas of bone that we target. So this diagram is a right orbit. And you can see the area shaded in blue here is the medial wall. The area shaded in green is the lateral wall. And then the posterior orbital floor, which is the part that I usually target, is shaded in red. And then the yellow shaded area is the lateral orbital rim, which we do remove sometimes if necessary. So for this particular patient, we did a 3-wall decompression. You can see him before and after. So in summary, there is a new treatment that's available. Certainly thyroid eye disease is a challenging autoimmune disease with several extrathyroid target tissues, including the orbit. One of the downsides of this is we don't have any sort of serum markers or disease predictors that we can follow. We can, however, monitor clinical activity by a scoring system. Medical therapy is effective in reducing inflammation, and the new medication, teprotumumab, appears to be the most promising. Surgery can also be effective in restoring the pre-disease appearance and function. And at this time, I'd like to thank the Saudi Ophthalmological Society for inviting me. It's a pleasure to be here. And again, I will take any questions. Thank you very much.
Thank you so much, Dr. Kikawa, for this really nice talk about the common disease we see. We see it less than what you see it in US, but still we see a good number of patients coming with this really tough disease to treat, which takes a long, let's say, time to reach the target. As you mentioned, it's a stage disease, and sometimes we need to go for medical therapy till things are stable. And the patient need to understand the long journey they need to go through. Plus, as you highlighted earlier on, the psychological support that we need to provide for these patients. We have some questions, and if you have any question, you can just post it, then we'll read it and we'll discuss it. There is a question: is how frequent fat decompression do you do, and do you? I mean, you didn't touch fat decompression, so what's your thought on that?
Yes, so fat decompression can be performed. Typically, I consider it for more mild cases. You do have to get intraconal fat to get the eye retro displaced. And I think if you concentrate primarily on the anterior fat, typically this will be kind of a cosmetic improvement, but we often combine intracoronal fat reduction as part of our bony decompression. So I use it as an adjunct, and if I perform it primarily, it's typically just for more mild cases.
There is a question from Dr. Habib, and he's sending his regard to you. And he says, do you know why the optic nerve compression takes long time to progress in thyroid eye disease? Why it doesn't happen so quickly?
Well, hello, Habib. How are you? Nice to hear from you. I think that there is some oddities that occur with optic neuropathy in thyroid eye disease. So I'm going to maybe take a different view and say that I think that the tolerance for the pressure that occurs with thyroid eye disease for the nerve seems to be longer than most optic neuropathies. For example, if you were to have a compressive optic neuropathy from a optic canal tumor, I think the margin for time is very narrow. We do see long-standing decompression, or excuse me, long-standing compression of the nerve in some patients that undergo orbital decompression that have had it for months, and they seem to have improvement. So I think it could occur very quickly, Habib. I mean, I think we see patients that have it occur within the period of weeks or so, sometimes even days. But I think there's a few oddities that we don't completely understand with how the nerve tolerates the compression for such a long time. And again, even with long-standing compression, we see some improvement over time.
That's good. Dr. Kikawa, you highlighted in the treatment of the medical treatment the use of Tibro and its improvement in proptosis. Do you get improvement in proptosis from using steroid and also other immunomodulator like tocilizumab?
Yeah, I think that's a good question, Adele. I think probably it has not been studied as in depth and undergone the rigorous trials that teprotumumab has undergone. I think most of the studies looking at tocilizumab or steroids have shown some improvement in clinical activity score and perhaps some improvement in proptosis. Even the peribulbar study that I showed that was by Ebner showed some improvement in proptosis. So I think it can occur as a treatment effect. We don't know the longevity, and even with teprotumumab, I mean, we don't know how long the effect lasts. There was some regression in the clinical trials. So until we see patients 5-10 years after the treatment, we really don't know the longevity.
That's good. We get a question from Dr. Samir from Jordan, and he's asking about, do you feel type 1 disease or type 2 disease is better candidate for decompression? Which one do better with the decompression?
Well, I think the type 1 or the fatty infiltration are the ones that do better because the fat can expand into the space a lot easier than large muscles. And consequently, there may be less risk to developing diplopia in patients with type 1 disease. The large muscle bellies that could be somewhat fibrotic don't expand quite as easily into the newly decompressed space. So I think the type 1 disease does better.
What about, do we need to control the anti-TSH antibodies before going to decompression, or we can go while it's not under complete control?
Well, I think it's always good to try and work with the endocrinologist to control the entire picture of the thyroid status. I think the antibodies themselves are a number, and I think we tend to look at the overall picture. So for example, if you're looking at the TSI, an absolute number may not correlate with the severity of disease. However, if you see trends in the TSI, if the TSI is progressing, then to me that's much more worrisome than just an absolute number. So if I guess to answer the question more directly, if we see this trending up, to me that's more of an indicator that there could be some underlying immune process that should be addressed prior to surgery. However, some patients, we're not going to perform surgery too frequently for acute processes, but sometimes if you're dealing with a patient with optic neuropathy, you don't have the luxury of controlling their immune status before performing surgery.
Good. There is a question about using botulinum toxin for treating the upper lid retraction. What's your experience with that, and how do you give it?
Yeah, so I have used it before, and I think there's two options with upper lid retraction. I think you can use botulinum toxin. I usually give it transconjunctival. So I'll elevate the lid and I'll give it just above the tarsus. And I usually give 1 to 2 units max. What you don't want to do is give too much and then deal with the ptosis. So that is effective. I think another option would be steroid injection. So in fact, I think in Japan, it's very, in Asia, it's very widely used to give 20 to 40 milligrams of triamcinolone or dipomedrol through the same route, and that appears to be effective in helping with the lid retraction.
There is a question about the teprotumumab mechanism of action or cycle. Somebody's asking, can you repeat what your thought about its work? You mentioned about the.
So I think the answer to that is still kind of unknown. Right now because of the pandemic, we're seeing some patients who are just completing their first cycle, but I think there was a crossover study that was done for patients that didn't respond as part of the phase 2 trial, and there was a percentage of patients that did respond to a second dose. So I think the answer is unknown. However, as part of the clinical trials and crossover studies, there was a group that was treated twice, and they did respond to the second treatment. I don't know if patients would be willing to undergo a second treatment if they failed the first. I think the question is probably needs to be discussed with each individual patient prior to giving a second round.
But I mean, do we need to go to 8 cycles, or we can 1 or 2 you can see effect immediately in these patients?
Well, that's a good question. So most patients do respond early on. I've had some patients that have had limited response early, but I think you'll find that even with the first or second cycle, some patients feel better and they get a good response. But the way the FDA approved the medication and the way that the clinical trials were performed, it was for 8 cycles total. And I don't know if a shorter course would have the same efficacy.
We get a question from Dr. Habibullah about using the teprotumumab for compressive optic neuropathy. Do you have experience with that? What's your thought?
Yeah, I've had one patient that had very mild optic neuropathy that we did have improvement with. It's one case. I think we're starting to hear of scattered reports of other cases where physicians have had improvement with teprotumumab for optic neuropathy. I think to answer your question, Habib, if you have a patient that's 2400 with a large paracentral scotoma with loss of color plates, that may not be the best candidate. However, in a patient maybe with early optic neuropathy where they have a little red desaturation with maybe 1 or 2 lines of vision drop, those patients are probably ones that I would try teprotumumab on for at least 1 or 2 cycles. So I think the jury is still out, Habib. I don't know the full answer. In my experience of one patient with mild optic neuropathy, it did improve.
Yeah, we get a question from Dr. Osama Ababna from Jordan. He's asking, why do we see severe cases of thyroid eye disease for patients who are hypothyroidism for years after thyroidectomy or even after radioactive iodine treatment? I mean, why it happened years after?
Yeah, it's a good question. We've seen some patients for 20 years, and the patient I presented had it 9 years after. So it's a good question. I don't think we know the full answer. I think the actual recurrence or the disease process in the orbit could be completely unrelated to the thyroid gland itself. So we do see probably a little bit of improvement of the orbitopathy in patients who have undergone surgical thyroidectomy, but I don't think there are hard and fast rules, and maybe there are other risk factors. Maybe these patients are smokers or other risk factors of why they get the orbitopathy after the thyroidectomy.
We get a question about thyroidectomy and when to consider thyroidectomy for patients who are having thyroid eye disease. Do you think thyroidectomy has something to do with controlling the disease? This is a question from one of the audience.
Yeah, I think so. There have been some population studies that correlate surgical thyroidectomy with improved eye disease, and there was one large study out of Michigan that showed that. I think some endocrinologists are considering it more. However, I still believe first-line therapy is radioactive iodine. But I think the thyroidectomy, it's an invasive procedure. It also has risks of removing the parathyroid gland and possible damage to the recurrent laryngeal nerve. So I think it's not in the right hands, it probably has minimal risk. But I think most endocrinologists are still considering RAI as a primary treatment.
There is a question, I'm not sure if this is really documented, is saying why some patients will have flaring of their thyroid eye disease after surgical thyroidectomy, and do you recommend prophylactic steroid as in radioactive iodine? I'm not sure if you have seen this one or not. After thyroidectomy, is there like a flare-up of thyroid eye disease?
Yeah, I have seen it, and typically my thinking is that the patient still has some, it's not necessarily an immune phenomenon, but it's the post-thyroidectomy hypothyroidism that causes this. And, think about, at least from a metabolic standpoint, do you have a patient that has relatively high metabolic activity in every tissue of the body? Once the gland is removed, these tissues now go into a hypothyroid state. And just the fact that these metabolic, the rates of the metabolism in these cells are slowing down, we see them gain weight because they're not hyperthyroid anymore. And think about the tissue around the eye probably also has a similar effect. So I don't think it's necessarily from the immune response as with RAI, but I think it's more from the post-hyperthyroid hypothyroidism.
That's good. I'm going to ask a question. I'm not sure what's your thought about. In Saudi Arabia, we have a lot of keratoconus patient, and after doing the cross-linking, the keratoconus progression is improved significantly in our population. What's your thought about immunomodulators and the need for surgical intervention in thyroid eye disease? Do you think that will affect the surgical rate, and if it does, what's your thought about the surgical option will be altered and the type of the surgery we need later on?
Yeah, I think most of the studies have shown that radiation and pulsed IV steroids don't have much effect on postoperative healing or response. Certainly we don't know yet if teprotumumab has any effect. My impression is that it probably wouldn't. But I think in terms of getting an adequate result, even in patients treated medically, I don't think it's so much of an issue.
That's good. In the diagram you showed about orbital floor decompression, the area was highlighted in red was a little bit small. So can you elaborate more how much orbital floor do you remove during orbital floor decompression? Yeah,
so I think the main complication that I see in floor decompression is when too much is removed. And it is a good question, Adele. I think if you come too far anterior, which is done in some cases by certain surgeons, I've seen hypoglobus where the eye sinks down, and then you also see occlusion of the maxillary ostium. So you see maxillary sinusitis. So I typically tend to preserve the anterior one half of the orbital floor, which corresponds to the area just posterior to the maxillary ostium, where you're not physically removing that bone of support. I also do take the strut out posteriorly. So I think that in conjunction with the posterior floor decompression is how I get my best effect. I also might add that is usually the third wall that I perform decompression on. So I'll usually do the lateral, the medial, then the floor.
That's good. We get a question from Dr. Yasser Faqi, and he's asking, when do you expect the clinical effect from teprotumumab after starting the treatment? And you just highlighted about the first cycle and second cycle. Can you elaborate more on that? like after a week, after 2 weeks, or?
Yes. Hello, Yasser. How are you? Hope you're doing well. So I think the clinical effect in most patients occurs fairly quickly. It's not a absolute response in every patient, but I would say, you know, in the patients that I've treated, I probably have about 30 under treatment or so, it occurs fairly rapidly. Not every patient will respond after that first injection. And I also might add that the first infusion is half the regular dose. So it's given as kind of a test dose, and then the medication is given at higher doses for cycles 2 through 8. But I would say usually the clinical response is fairly rapid, so after the first or second infusion.
And what's your treatment protocol now for compressive optic neuropathy? Because there are several questions about using teprotumumab as in patients with compressive optic neuropathy. So,
yeah, good question, Yasser. You know, I think that again, every patient needs to be treated individually, and if it was a rip-roaring optic nerve compression with 2400 vision or hand motion vision, with you know, huge central scotoma and no color perception at all, I don't think we have the luxury to wait for those patients. So I would probably go straight to surgery in that patient if you've exhausted, you know, the steroids or radiation. But again, I think if it's a more mild, where you see perhaps a little bit of red desaturation or 1 or 2 drops of vision, 1 or 2 lines of drop in vision, then I think they may, you might have some luxury in waiting and trying other options.
that's good. I don't see more questions, and thank you so much, Dr. Kikawa. We appreciate your time and sharing your wonderful experience, and I thank all the participants to be with us Friday night, and wish you all good time and have good night in Saudi Arabia and good day in US. Thank you so much.
Thank you very much. Thank you, Adele, and thanks to the Saudi Ophthalmological Society for inviting me.